Hello, welcome to this little live link. Please put any questions into the box using the link that should be on your screen. I'm Dr Naomi Sutton. I'm going to be talking about sexually transmitted infections mainly today, but if you've got any other questions and you've got time, then we will cover them. I am a sexual health consultant. I work at Rotherham. I'm also passionate about all things sex. That's a silly thing to say. Everybody's passionate about all things sex. I also did some work on the TV with a series called The Sex Clinic on Channel 4 and also Steph's Packed Lunch, which was all live TV. And yeah, so what I want to do is basically set the scene to start with. So first of all, I want everyone to think about how we think about STIs. They're often really shamed. They're often very stigmatized. And it's an odd thing because most of us or all of us who are of a consenting age either want to have sex or are having sex, and we don't have the same issue when it comes to checking our blood pressure or coming to see the doctor because of a cold. So again, this is because of cultural and societal pressures of the way we think about sex and how we view people with STIs or testing for STIs. So hopefully at the end of this, hopefully I will have dismantled a few myths, because my point is really to encourage everybody to get tested. The other thing to think about as well is that sex is a quality of life indicator, and so actually it's really important that we have healthy, fun, pleasurable sex, and so part of that is having a good sexual health. So being able to test freely, use contraception, understand our own sexuality, ensure things are pleasurable, etc. It's really important as well to think about what is an STI. So a sexually transmitted infection is something obviously that is transmitted through sex. There's bacteria, viruses and parasites. I'm going to talk about the main ones today. So I'm going to be talking about chlamydia, gonorrhea, HIV, syphilis, genital warts and herpes, again if I have time. And the other thing to consider is that rates change. Now, rates of STIs will change because of lots of different reasons. So it's not only testing that changes rates, but it's also our own behaviours. So societal and cultural shifts in how we see things, but also medical advances. So if I give an example, in the 1940s, penicillin was found or invented. And so that reduced syphilis rates from quite high levels, really low down. And then in the 60s, there was a combined oral contraceptive pill for women. So that allowed women to have sex for sexual pleasure, not just have a baby. So it allowed sexual liberation. And then I'm sure most of you have heard of the AIDS crisis. So in the early 80s, there was the big campaign in the UK where the tombstone adverts happened, and basically we see a massive reduction in all STIs across the board, because people really didn't have sex for a good decade. And then we got treatment for HIV, and I'm going to touch a little bit on that. And then so the fear of HIV reduces a bit, so people go back to doing what they want to do and having hopefully a nicer sex life. And then when we look at rates today, syphilis, gonorrhea, HIV, they're all on the rise, and we need to think about why that's happening. So first of all, the number of partners that we're having is increasing. So there's big UK data showing that the number of sexual partners we have is going up compared to previous generations. We can also meet people very easily on dating apps and things like that. Condom use is pretty low. Lots of reasons for that, which we can talk about if we get time. And the other thing is, obviously, I'm going to talk about that, but HIV is no longer a life-threatening condition. You can't pass it on if you live with HIV and you have treatment. So therefore, there's less impetus to use condoms if you live with HIV. And also, if you are high risk of HIV, people can also take pre-exposure prophylaxis to stop them getting HIV. And we also have lots of vaccines. So the HPV vaccine has been huge in reducing the number of genital warts that we see. And there's now a gonorrhea vaccine for people who are high risk of that, which is probably protective in about 30 to 40% of people. And again, available to those at high risk of getting gonorrhea. Anyway, so what I'm going to try and do is talk about each infection separately, and then go on and answer questions if we've got time. So I'm going to start with chlamydia, and the reason I'm starting with that is because it's the most common STI that we diagnose in the UK. So it's a bacteria. When we think about transmission rates, it's transmitted through oral sex, anal sex, vaginal sex, so any kind of sex, and in the vast majority of the people, it won't have any symptoms. So in women, 80% of people will have no symptoms at all of chlamydia. It's in men, if they have it in their urethra, so within the penis, they have about a 50% chance of having a symptom. Rectal and pharyngeal infections are rarely symptomatic. When I say symptomatic, that means they've got symptoms. If you have sex with someone with chlamydia, the chances you are very likely to get it. So it's about a 75% chance that if you have sex with someone without a condom, you will get chlamydia from them from one episode. And the issue is with chlamydia is if left untreated, it can cause long-term problems. So in women, it can go on and cause pelvic inflammatory disease. So that's inflammation of your pelvic organs, including your tubes that lead to your ovaries. That can then go on and cause problems with fertility, because if it scars up all your tubes, the eggs can't pass down happily, or you can have ectopic pregnancies, which is where the blastocyst, the egg and the sperm that have met, get stuck in the tube and they can't pass through the scarred tube. And in men, it can cause epididymorchitis. And again, when we're thinking about pelvic inflammatory disease, 1 in 10 women with chlamydia are likely to go on and get pelvic inflammatory disease. So it's a high proportion of people who are going to struggle with this, and often it can be subclinical. So even women with PID may not know that they've got it. So it doesn't always present with abdominal pain, etc. So the only way that we know you haven't got chlamydia is to get screened. And when we look at the chlamydia screening programs, that's women under the age of 25. Out of those people screened, 1 in 10 will have chlamydia. So it's really common. So please get tested for chlamydia, all STIs. To get tested, you can go to your GP and ask for a screen, or you can test online. Wherever you live, there will be online services, or you can pop into your sexual health service. So if you live in Rotherham, you can give us a ring. We do what we call a screen and go. So you can just come in, see one of our healthcare assistants. They will give you the swabs to do in the toilet. You don't even need to take your knickers off or get your willy out. You do a first pass urine for a man, and then there's rectal, pharyngeal and vaginal swabs depending on what type of sex you're having. And I have one here which I'm going to open. So this is what we'd use for the rectal, pharyngeal and vaginal swab. So it's a simple test. I'm going to waste it and open it up. It's just a cotton bud, goes into whichever orifice you need to swab, and then you undo this cap, pop it in, and then you bring that back to your healthcare assistant. It is really simple. It's not painful. It's very easy to do, and it's an incredibly sensitive test. So if it's negative, you can be really reassured that you haven't got gonorrhea or chlamydia. To talk about window period, so if you've had a risk or you're wanting to check you haven't had an infection from that specific person, you have to wait at least 2 weeks before swabbing. So that's what we call a window period, to check that you haven't got something from that specific episode. And yeah, treatment's really easy. A week of antibiotics in general. Yeah, I think that's all on chlamydia. Any questions? Have I covered it? I've got some people in the room who are keeping me going. Okay, so that's chlamydia. Again, really common, really easy to treat. Most people don't have symptoms. And the most common STI, so about 50% of STIs in the UK. When we look at gonorrhea, rates are going through the roof at the moment. So rates the highest we've ever had since screening began in 1918. So when the Venereal Diseases Act came in and STI treatment became free to all. So for us, this is really worrying. Again, it's a bacteria. It's more likely to cause symptoms in both sexes, so it can often cause a discharge, pain or burning when you pass water, sometimes bleeding in between periods or bleeding after sex. If you're a woman, sometimes anal discharge or anal symptoms if you're having anal sex. Most commonly pharyngeal infections, so infection in the throat won't have any symptoms. But again, very easy to pass through unprotected sex. The problem we have at the moment is resistance to antibiotics. So it's become resistant to most antibiotic that we have. We're on our last line of defence. There's multi-resistant strains of gonorrhea. So what would happen if you did have gonorrhea diagnosed in a GP practice? You should be sent into sexual health for us to culture it and make sure that we know the sensitivities before you get treatment. But again, that same swab should be done for both gonorrhea and chlamydia, so you should pick up both. And again, with all of these, both those bacterial infections, it's really important that we let partners know so that we can break that chain of onward transmission. And if you go to a sexual health clinic, we can help with contact tracing. So that's really important. Again, treatment is easy with antibiotics. Often it can be an injection in the bum, which some people don't like, but sometimes we can give oral antibiotics depending on whether you've got resistance or not to the antibiotics. The next one I want to talk about is syphilis, which is my favourite because I have treponema tresses. So syphilis looks like my hair under the microscope. They're little curly spiral sheets. Again, it's a type of bacteria. So it's a really old disease, I suppose. So it came over, I think it was Napoleon times, I'm not very good at my history, but 14th, 15th century. And it was pretty widespread in the 19th century, etc. And again, really stigmatized, and people used to associate it with gambling and alcoholism and overwork and overstress. And we didn't realize really what bacteria were or what was causing this disease. And there was no treatment. People used to be given mercury and lead, and that used to often kill people or give worse symptoms than the syphilis did. And then when we developed penicillin, we realized that it was caused by a bacteria in about 1908, and then we developed penicillin, which we found out treated it. So it is now a treatable, manageable condition. Rates were very, very low up until probably 2000s. Since then, they have been climbing like that. So we've had about a 300% increase over the last 20 years in rates. When I was training, which was a long time ago, I never saw any syphilis. It was one of those things that you just sort of deleted those files because they were unnecessary. And now we see it really regularly, even in Rotherham, which is, it's a pretty standard demographic that we deal with, but we see syphilis a lot in both heterosexuals and men who have sex with men. So I think a lot of people feel syphilis is confined to men who have sex with men, but that is not the case. We're even seeing it in pregnant women, and we've had babies born with syphilis, which is a really awful thing because it's it can cause early miscarriage and significant disease in the baby. Syphilis is quite complex in the stages, but I'm going to try and keep it simple. Again, syphilis is through skin-to-skin contact with someone who's already got the infection. Depending on what type of sex you have, depends on where you get your first sign. So that's often a chancre, which is it's a clean-based ulcer in most people. Most of the time, it's just a single one, but often it's painless. So if you are having vaginal sex, for example, your chancre might be in your vagina. If it's painless, you're not going to notice it. And if you're having anal sex, for example, and it's in your anus, you're not going to notice it. If it's in your throat, you're not going to notice it. So if you do have a penis and you have an ulcer, it's really, really, really important that people consider syphilis. And part of my problem as a sexual health consultant is a lot of medical healthcare professionals don't realise that syphilis is on the rise. So sometimes these things are missed or not thought about. And again, as medical professionals, we're not infallible. We also judge people. And so people who are, say, 50, white, heterosexual, married, or used to be married women or whatever, may present with an ulcer, we wouldn't necessarily think, oh, they're definitely going to have syphilis. So again, part of my job in my field is to educate people just to please advocate for yourself to get tested. So once the infection gets into the system through that chancre, it then becomes a systemic infection. So you may or may not have noticed any symptoms if you did have it. You then develop secondary syphilis, which is often a widespread rash, or you might get patchy alopecia. That's when bits of your hair fall out. Or it can cause cranial nerve palsy, so you might have eye problems or ear problems, or it can affect your liver or your kidneys. And again, these symptoms often resolve on their own, even without treatment. And then if syphilis is left untreated long term, it can go on and affect your heart, your bones, and your brain and all your nerves. So long term, it can cause significant problems with your health. And infection wise, you're infectious from 2 years, from the point of picking up the infection for 2 years. So it's a long time where you could be passing this infection on to somebody else. And you don't always have any symptoms. So you may have gone through that whole stage with no symptoms at all, but you could still be passing that on. So again, we all need to be more aware that syphilis is on the rise, and advocate, if you're a patient, advocate for yourself to get tested, and for healthcare professionals to be aware that it's really important to test. And then I want to talk about HIV. So again, HIV is, again, a hugely stigmatized virus, and it's really not necessary to be stigmatized, because like everybody else, nobody wants to have HIV. No one deserves to have HIV. You don't have to do anything specific to get HIV. We have patients who've had sex with one person and got HIV. We've had people who've had sex with hundreds of people and have HIV. So again, this sort of misinformation about the fact that you have to have had sex with millions of people to get it. One, it doesn't matter anyway. Why are we to judge them anyway? But it, you don't have to fit a certain stereotype to have HIV, and it can be really difficult sitting in a room speaking to somebody who's so heavily stigmatized to make them feel better. So the reason it's so stigmatized is because there's so much fear about the infection. So it was in the 1980s when we started seeing people with what we call opportunistic infections, so strange infections, because the HIV virus basically slowly over time destroys your immune system. So you get infections that we wouldn't normally see in people who have normal immunity. And there was no treatment for a long, long time. Now, living with HIV in 2026, it's a chronic, manageable condition. People can go on and have babies. You can work as a surgeon, even doing exposure-borne procedures. You are the least risky person to have sex with because you can't pass the virus on to sexual partners. So if you are happy to have sex with someone without a condom who you don't know their status, that's more risky than having someone who is open about having HIV, if that makes sense. So part of my problem, I sit there in clinic and someone will say, well, I keep getting ghosted, or, people disown me when they know I've got HIV. Actually, they're the safest people to sleep with or have sex with because they've got HIV that's manageable. Once they're on treatment, their viral load's undetectable. They can't pass the virus on to sexual partners. Whereas somebody out there, it used to be the lead mill or whatever, we used to go and sexy type jokes. But, wherever people go to hook up, having sex with someone who doesn't know the status, hasn't been tested, is more risky. So we really need to rethink how we view people living with HIV. So really important. The campaign is called You Equals You, or You Can't Pass It On. It's a massive campaign. It came out about 6 years ago now. And again, it's a double-edged sword. So it's brilliant and hopefully destigmatizing for people living with HIV and to get the message out there. But again, as I said before, possibly some of the reason why other STIs are going up, because there's less fear about HIV. When fear of infections, things goes down, people do generally have more sex or sex without condoms, with etc. But yeah, trying to think what else I need to say about HIV. Yeah, you can have babies that don't have HIV. Oh, that was another thing. Rates of HIV are going up again. So since for the last 4 years or so, rates of HIV are going up, and the rates are going up in heterosexual people. Now, again, we prejudge who has HIV, and often we think it's white gay men or black heterosexual population. That is not true. The people who get diagnosed latest with HIV are often white heterosexual men, because they're not testing pregnancy and they don't present with any what we typically describe as risk factors. So again, really, really important. It's HIV testing week starting on Monday, the 9th. So please, if you've never been tested for gonorrhea, chlamydia, HIV and syphilis, please come in and see us or do an online test for all those 4 infections. Because, as I say, if you have HIV and you don't have it managed, you are personally going to run into problems and get late stage HIV and potentially die. And also you can keep passing it on to other people. If you do get tested and you're positive, again, it's manageable, treatable. You get to see me every few weeks. No, not every week. I don't even see you every week. But you know, we manage people with HIV. We're like a big happy family. So every cloud has a silver lining. But yeah, no disadvantages to testing. Everything is manageable or treatable with all those things that I've talked about. I want to mention the herpes simplex virus. So that's the cold sore virus, or herpes as people might know it as. So there's 2 types of the virus. There's type 1 and there's type 2. So lots of people might have oral cold sores. That's more common to be type 1. But down below, it's about 50-50 into what we pick up. Both types, type 1 and type 2 of the herpes simplex virus, cause the same symptoms. So genital herpes. The symptoms generally are little ulcers, soreness, pain when you pass water because of the open skin. And that's all it does. It doesn't cause infertility, it doesn't cause PID, it doesn't cause anything awful, it doesn't affect your immunity, it's not going to kill you, yet it causes a lot of stress and stigma. And so what I want to do is try and put this in perspective. So it's the same family of viruses as the chickenpox virus. We don't shame people for having chickenpox, which can reactivate to cause shingles, yet people with genital herpes feel shamed and stigmatized and think they're never going to have sex with anybody ever again, and it's really ridiculous. And it's also really important to know that about 70% of us by the time we reach 40 have the virus on board anyway. So it's a state of normality to have the virus. It's much more unusual not to have the virus than it is to have it. And again, most people won't have any symptoms ever. And again, it doesn't do anything to hurt you, other than if it does recur, it can cause the odd little blister or symptom. If it does cause problems, we can put people on suppressive therapy, etc. Please come and see us if you are struggling with it. But again, it really should be demystified and destigmatized. And the only reason it is so stigmatized is because it was in the 70s and 80s, the drug manufacturers of acyclovir, which is the antiviral that we use to treat it, needed a cohort of patients to treat. And so they had a massive campaign about the herpes virus, and it was the Scarlet Letter and all these massive advertising campaigns. Before that time, no one would even worry if they had an ulcer. So again, we need to try and keep that in perspective. A really good place to look for more information is the Herpes Simplex Association, hsa.org, I think it is, but we can add it to the link later. And they even have a helpline, so you can phone them if you're panicking, if you can't get in to see whoever. And then also people get confused between HSV, so the herpes simplex virus, and HPV, so human papilloma virus. So there is about 200 different strains of the human papilloma virus, about 40 that affect genital skin. If you get a genital wart, it's more likely to be type 6 and 11, but there are other types that we class as oncogenic. So generally genital warts are benign. They're not going to cause any cancerous problem. They just cause a lump in the skin, so a typical genital wart. And then there are lots of other types that we know are oncogenic, which means they can over time cause cancer. So the HPV vaccination program is vaccinating against some oncogenic types, the most common ones that will cause cervical cancer, anal cancer, penile cancer, vaginal cancer, vulval cancer, throat cancer, and the genital wart types. So that's the one infection that we've seen go down dramatically because of the vaccination program. So it's really important if you're a female and you've had a cervical screening test, if you get the high risk HPV, don't panic about it. It is something that we test for in everybody. It doesn't mean someone's been having sex with someone else or whatever. You can't say when you picked up this virus. Sometimes you can shed it more than other times. So it may be that one time it was negative and then it's come back again or whatever. We don't really understand the mechanisms behind that necessarily. But the important thing is that what they will do at the testing is they test for the high risk HPV. If you do have it, then they look at the cells to see if the cells are abnormal, and then they will either put you into going to colposcopy if some of the cells are abnormal, or they'll just put you back to a yearly screen if you have this high risk HPV virus. And hopefully in the next, I think this year, they're supposed to be bringing out swabs for HPV for people who find cervical screening really difficult. And having a smear test or a cervical screening isn't easy. Lots of women have suffered sexual abuse or trauma, or they just, don't like the idea of being fiddled around with. But again, I see it as an empowering thing for women to do because you're looking after your health. So if you are worried, please come and talk to us. There are lots of things that we can do to help make the process as easy as possible for you. But again, so they're separate things. If you do, getting back to warts, if you do have genital warts, again, you can have the HPV virus 6 and 11 without having any symptoms. If it does cause lumps in the skin, you can treat them with, we can freeze them or we can give you creams to use at home. Again, we can't get rid of the virus itself often. Your body has to do that. But things that can help are stopping smoking. So if you are a smoker and you have a high risk or any type of HPV, stopping smoking can help your body to rid yourself of the virus. And just, if you're diabetic, keeping your diabetes control really tight, again, can help with that. I think that's it about warts. Again, skin on skin contact, and it's through sort of microabrasions. On the subject of prevention, because I think that's important, obviously condoms are the only thing we have to prevent STI transmission. Warts and herpes, obviously you're only protecting the glands and the shaft of the penis, so skin on skin contact, those viruses can be transmitted, but you will not pass on HIV. If you use a condom, you're very likely to pass on gonorrhea, chlamydia, or syphilis, although again, it depends what you're doing. But again, condoms are really good. Make sure you've had your HPV vaccine if you're within that age cohort. And there are vaccines for people who are high risk. So the gonorrhea vaccine, the monkeypox vaccine, Hep B vaccine. And consider, if, especially men who have sex with men, if you are having condomless anal sex, please come and talk to us about PrEP. And again, screen. There are no drawbacks to screening other than you have to walk through the door or order an online test. And again, that's our own cultural silliness about stigma, which hopefully will be less after this stream. And obviously if you do test and find something, we can treat it and then stop onward transmission. Right, I'm going to see if there's any questions. Have you got any questions? Right, okay. Can I get an STI at swimming? No. No, I'm not being facetious. No, you can't. That's another thing as well. So you can't get STIs from, you definitely can't get HIV from kissing, using people's utensils, sitting on the same toilet seat, etc., etc. And you can't do that. So things like scabies that we do sometimes classed as an STI, if they're on the genitals, you can get from sharing towels, etc. But bacteria and viruses don't live outside the body long enough to be transmitted through things like swimming pools and things like that. So don't worry about that. What's the best way to wash genitals? It's a good question. With water. It's really important if you have very delicate skin to consider what you're putting on it, but there isn't any problem with using soap in the vast majority of people. If you do have very dry skin, or you're having problems or you're allergic to anything, obviously use a soap substitute or just water. Importantly for women is you should not wash beyond the labia. So the actual vagina, so that's the tube inside your body, doesn't need washing. If you do wash the vagina, so if you douche, you will wash away all the good microbiome, and then you're much more likely to get bacterial vaginosis or thrush. So please don't do that. What problems do people usually wait too long to get checked? I guess kind of everything and anything, and again that depends on, often it's internalized stigma, and that depends on how we've been brought up, how we are taught to talk about sex. So again, if you're a parent, you've got children, please think about the raised eyebrow and the awkwardness that you feel talking about sex, because 95% of communication, or maybe slightly less, is not verbal. So it's not what we say, it's how we say it, the tone of voice, our facial expression. And if we feel, as parents, or someone who's talking to other people about sex, if we feel stigmatized or awkward or embarrassed, it's going to come out, it will flow off you, and people learn very quickly to shut down and to not ask questions. So again, people wait too long to get tested, or to come with a problem because they're too embarrassed. And again, that's because of the world we live in, which we are not going to sort out today, but again, we can sort individuals out, hopefully. What does yellow discharge mean? So any kind of discharge in a man could mean gonorrhea or chlamydia, could also mean trichomoniasis or TB. That's a parasitic STI that I haven't mentioned. But again, if you have any kind of discharge, as a man, you need to come and get screened. If it's a woman and you have yellowish discharge, that could just be bacterial vaginosis, or it could just be normal for you. I don't know what sex the person that was. Why do I get a stabbing pain after or during sex, but I've been tested? Okay, that's a whole nother bundle of discussion, which I might have to come back and do again, because that sounds more like a sexual function or issue. So I'm not going to touch on that today, because I'll go down a rabbit hole. Any myths and misunderstandings that cause the most harm? Yeah, I think thinking that somebody, that judging someone by how they look means they know whether they've got an STI or not. You can't judge. They could be old, young, black, green, white, man, woman, it really doesn't matter. Anybody can have an STI. And also, and this sounds not a nice thing to think about, but even if you're in a long-term relationship, it doesn't mean that you can't have an STI, because you never know what the other person's doing. So again, if I see someone with a symptom, I don't really care what they tell me their sexual history is, because you're only assessing that one person sitting in front of you. Right. There's some sexual function ones. How often should someone realistically get a sexual health checkups or screening? Again, it depends who you're having sex with. So men who have sex with men are slightly higher risk, because STIs do affect that population more. But also if you're younger, so STIs in the younger population are much higher, although actually STIs in the older age group are going up the fastest. So although they're not the greatest proportion, the acceleration in heterosexuals over the age of 45 is the group that's going up most. So yeah, depends on how many partners you have, but I think at every change of partner. And I also hear a lot people use condoms for the first few months of relationship, and then they go, oh, but we love each other now, and so we're not using condoms, which is lovely, and I love, but it still doesn't mean that no one has an STI. So before you stop using condoms, if you're in a relationship where that is happening, please get tested before you use condoms if you plan to be monogamous going forwards. So it's really important that you test before you stop the protection, because, as I said, lots of these things can be there without any symptoms. My friend has HIV. Will I catch it easily? Absolutely not. So I was talking about chlamydia, really easy to get it. So if you have sex with someone with chlamydia, you're pretty likely to get it. With HIV, it's actually quite a difficult virus to catch. So it's more readily transmitted through receptive anal sex. That's the biggest risk. You can transmit it through oh gosh, I get my insertive and receptors wrong. But you can transmit it through vaginal sex, but it's much less likely because generally there's less trauma. But say if somebody comes to see me who's been sexually assaulted, for example, I'd be much more likely to potentially consider post-exposure prophylaxis for HIV, because trauma and blood are obviously going to transmit the virus more readily. And that's why men who have sex with men have a higher infection rate, is because anal sex is generally more traumatic. So that's why. But you can't catch it if you're not actually having penetrative sex of some description with your friend. And again, if they're on treatment, you can't get it. Impossible, as long as they're taking it. So yeah. What time is it? Am I? Yeah, still good to go. And then I've got one question: is anal bleeding normal? No. No. So any kind of weird, strange bleeding, wherever it's coming from, really for whether it was painful, whether it's painless, how old you were, what your history was. So, but if it's something that's new to you, I would definitely go and get medical advice, because we just need to ask a few more questions. Any questions from you guys?
Do you want to talk about what it's like to go and get tested?
Oh yes, yeah. So if you come to, so you go to your GP and ask for tests, or you can do online testing. So even if you're not in Rotherham, there should be, if you put in, if you search for online testing, your local sexual health service should provide that. But if you want to come in and see us, you could just ring us up, Google Sexual Health Rotherham, give us a ring. Our receptionists are all really lovely. They will try and ask you a very few questions about what you need. If you just say, I want to be screened, they will generally, if you've got no symptoms, they'll book you in with one of our lovely healthcare assistants who'll do a screen and go. And again, if you've got something that you want to talk to us about, if you've got a symptom, anal bleeding or strange discharge or whatever else that you want to talk to us about, then book in to see one of our clinical teams. That'll be a nurse or a doctor. We're all delightful. We're all friendly. No one's going to stigmatise you. There is nothing you can say that we haven't heard before or that we will be shocked by. I think, pretty sure. I've been in this job too long to be shocked. But please don't let internal stigma stop you looking after your own health, because honestly, you'll feel better with whatever the outcome of testing is once it's done. Yeah. And as I say, if you've got no symptoms, you don't need to get your genitals out. Just go to the toilet and do it yourself. Because that's often people's fear, is that we're going to, have to look at their genitals. And yes, we sometimes do if you've got symptoms. But again, we look at genitals all day. We won't remember your genitals, I promise. People worry. We're just thinking about what we're going to have for tea, or, I don't know, whatever we're thinking about. But I promise we're not. We don't care whether you've shaved or, you've got, I don't know. Anyway, yeah, I promise we don't care. But yeah, I've got another question. Oh, When having a screening test, how long does it take to get the results to come through? So we normally say within a couple of weeks. It's normally much quicker. So turnaround's normally within a few days. And as I say, just remember that window period. So I didn't mention HIV and syphilis, but for gonorrhea and chlamydia, we say it's a 2-week window period. So say you have sex tonight with someone you like, oh, I didn't use a condom, I want to get screened. You can come whenever, but if you want to make sure you haven't got gonorrhea and chlamydia, you need to wait 2 weeks. And for HIV and syphilis, that's 3 months. But turnaround's pretty speedy. I think that's on. I've got a hello. Hello. Fab. I think I'm going to wrap up if no one has any more questions, but I hope to see some of you in clinic. Obviously, I don't know who you are, but say hi if you've seen it. And yeah, thanks for engaging and thanks for your attention.